What did Eleanor's mother pass away?
She fainted in.
Did she have any issues?
She fainted and herself. She had bleeding in the brain. She was admitted in ICU for 2 days.
But she was still coming here, right, Elena? She was.
What age?
Must be very young because Elena is very young. Maybe
She's the only one.
Maybe 40, 44 years. So today you need to give me 19 verses. You get 20 minutes late. Now,
Only is the bacteria's endophthalmitis normal? Important.
or yes, Operative Pseudomonas. Okay. So there are what is the treatment for endophthalmitis?
One mg.
Drinking.
Oh.
Take vancomycin drinking.
1 ml.
Drink 1 ml vancomycin.
I
intravitreal vancomycin 1 mg per 0.1 per 0.1.
Then next.
Ceftazidime 2.5 mg 2.25
mg
per 0.1.
Okay. Then what else? Symptoms of endophthalmitis. Fatima. First.
decrease of vision, pain,
Yeah.
and
Condition.
condition.
All useless symptoms you told. Okay, actually symptoms that's fine.
Yeah.
Tell me signs.
Hypopure.
Very good.
Vitreous.
Vitritis. No, don't look. Yes, please.
5
It's okay. Take a call. Come back.
fibroids.
Fibrin.
Fingertips.
Okay, then.
Sir, I'll go to contact.
No problem. AC cells, fibrin, vitritis, hypopyon.
Increased red reflex. Finger.
Fine. Tell me. I think we covered most of the things, right? Treatment, you guys forgot something. We can give steroids also. Treatment is a little bit complicated.
Atropine.
Atropine. Prevention. How do you prevent? So,
And take before post endophthalmitis surgery treatment. We prophylact it with
everything you are saying except the answer.
Orbital
Say iodine.
iodine.
Iodine the same. Or povidone iodine. 5% povidone iodine. Eye drops in penetrable. So today we will study what to do if it comes.
Subject.
Hello. నేను డాక్టర్ అండి నాకు బిజీ విత్ పేషెంట్స్ Fatima is very
What?
you We're very happy.
I have this tendency to
Dina, Fatima, you're sitting. Subacute. Now, so this was immediately if it happens, we are supposed to treat it like that. Okay? Especially when do we treat with all these things when there is vision drop to PL suddenly. So we do not wait. We do not wait for a week and then we immediately do it. Otherwise, if there is no vision drop, then we wait for a week for it to resolve. Yeah. Or was it lower fractures?
think if the vision is reduced to PL, give diagnostic culture. If it is post-cataract, after for surgery, cataract, then
Very
we
important point. We are supposed to give diagnostic culture of the aqueous and the vitreous also. When do we give diagnostic culture? Where do we give diagnostic culture? How many culture plates do we use?
KOH mount,
KOH.
KOH mount, blood agar, chocolate agar, sab roots,
For vitreal culture and aqueous chamber phagocytosis. Okay, vitreous trap and aqueous trap. Come on. Now let's read what we do if it is happening 1 month or 2 months or 6 months after surgery. Yes, please. Fatima, read.
Subacute, weeks to months after surgery. Symptoms: variable, insidious, decreased vision, increasing redness and pain.
No, very fast you're going. Did you understand anything you said? Or just reading it like English class? What did you understand?
Decreased vision and redness and pain.
Insidious decreased vision.
Yeah, insidious.
Decreased was there also. Insidious means? Have you seen the movie Conjuring?
Yes.
Have you seen the movie Insidious?
Yes.
What does insidious mean? Scary. Chumma, whatever else you say, yes?
It's very
Insidious means sneaking upon you.
Yeah.
Something that has such a insidious concept, like you don't even know when it is growing. Like glaucoma. Glaucoma can have insidious.
Ghost.
Yeah. One day you will wake up and you will be a nun. That's scary. Nun will be scary. So insidious decreased vision, increased redness and pain. Critical.
Signs: critical, anterior chamber and vitreous inflammation,
Obviously.
vitreous abscess,
So this point, vitritis is not the same. Vitritis is a short-lived early symptom, but by this time there has been enough things happening that now the vitreous has pus also. Then vitreous abscess. This because it's long term. Hypoparan obviously.
hypopia, clouds of exudate in the anterior chamber,
Little more thick exudates are there, not like just fibrillate, but more thicker because chronic it's there. On the iris
on the
surface,
iris
so
surface,
everything that is happening in this acute post-operative dermatitis is much more defined and more granular and more solid like that. Okay, please.
other corneal infiltrate and edema may have a surgical bleb.
Yeah, because look for bleb. If you're looking at endophthalmitis, look for a bleb. Endophthalmitis rarely happens with post-cataract or post-trabecular.
Or organisms, S. epidermidis, or other common bacteria.
Always, anything happens to the eye, always try to blame epidermidis. Or
Or
yes.
other
Why?
bacteria.
Why is epidermitis so commonly causing?
Skin, it's like
Yes, on the skin.
it's a
Eye
common
is having a huge skin flap. Yes. Then Propionibacterium.
Propionibacteria, Bacillus, or other rare indolent bacteria.
What is the meaning of indolent? Okay. Such a
I was thinking same thing. Lazy.
okay.
A disease causing little or no pain.
So basically it means like a slow growing bacteria. That's why it took 6 months to come in. Yeah? Propionibacterium. There is current.
Recurrent granulomatous anterior uveitis, often with a hypopion, and granulomatous keratic precipitates.
No, why are you going so fast? Did you understand every word you said? No.
Okay,
Tell recurrent
yeah. Recurrent
means again and again and again and again. It happened for 1 month, it stopped. Then 3 months it stopped. Then 6 months again it came more severe. Then granulomatous anterior uveitis. You understand this point? So same thing like there were clumps of exudates in the anterior chamber. Similarly, you will also have some granular exudates like very thick. Cells are not the small cell, bigger cells are there in the anterior chamber.
often with a hypopion and granulomatous keratic precipitates.
Butterfat KPs, all those things. Keratic precipitates like on the underthelum there are small big exudates that are stuck. That is what is happening. Okay, next.
But with minimal conjunctival injection and pain.
So the strange thing about this is propionibacterium that you girls have noticed or not, I don't know, but is the fact that there is no pain. Whereas staph aureus, they will have severe pain. Actually, severe pain, they will have pain. Patient will say that I am having pain. Actually, today, minimal pain. Okay? A white plaque or opacity on the lens capsule also may be there. That also strange. Okay.
Only a transient response to steroids.
Steroids will respond a little bit and then go back. Next.
Fungi, Aspergillus, Candida, Cephalosporium, Penicillium species. Differential.
Is there a table there? There is a table. There is no table.
There must be page number.
It is a table.
So for chronic post-operative,
Yeah, it is.
that's actually a page. Because the next page is actually.
Yeah, where is it?
Comes.
Okay, okay. Let's see what is the different diagnosis. Okay. Read from there.
Chronic post-operative. Same other topic actually.
Yeah, definite diagnosis. So definite diagnosis is only chronic post-operative. That's
So post-operative information is
fine.
typically.
No, it's okay. No.
It's another chapter. Actually.
Yeah, I got it.
It's another topic.
So not just list is a second.
Yeah.
One thing is there that looks like endophthalmitis. This is chronic post-operative event. That's it. Okay, fine. What else? Workup. Can you try to tell me workup without looking? Fatima.
History examination.
The history taking part is very good for you because definitely for delayed onset endophthalmitis you have to take a history. The biggest clue is history because if she doesn't say that she had an operation 6 months back, then it's very misleading. If she says any operation then it should not be taken lightly. There's always a chance of post delayed onset endophthalmitis. Okay. Yeah. Then
Culture.
what culture?
With
Vitreous tab, aqueous tab. So I think what happened? Vitreous tab, aqueous tab. Forgot? You have to take vitreous. You have to take vitreous fluid. That's called vitreous tab. Don't just say culture. Culture of the vitreous tab, culture of the aqueous tab. Where you will do culture again? Your way, ramstein, chocolate, blood agar, some. What else you can do? Maybe we can do this scan. What else we can do? We can look at the visual acuity to see whether the visual acuity is improving. Then we can also see that. What else we can do? Anything else? Anything else? Huh?
Aspiration of vitreous for gram stain cultures. Yes, we have that already. A solid medium, thioglycolate. That's why thioglycolate was coming again and again yesterday, and I was trying to skip it. But the thing is, thioglycolate and a solid medium for anaerobic cultures. P acnes will be missed unless proper anaerobic cultures are made. So if it's a P acnes, you have to think about an anaerobic culture as well, apart from these 5 places. So we talked about 5 things yesterday, right? We also have to think of something extra. Second place. Let's put anything coming out?
I see the place.
I need to move it.
My God.
I told you I wanted to keep it over.
That makes sense. Yeah, it's true. If it's here, it will cause a nuisance for the patient.
It will go away fast.
It's a nice smell, but it's like here nonsense.
Good. Anyway. No, it's not 10.
With a
It was 5. We'll keep it at 4. We'll keep it at 5 for a time. Yes. Yes, girls. No. Yes, ma'am. Yes. The fees used to be 55, ma'am. Then the batch paid 60. Now they are quoting 65 this year. 65. You got 65. Actually, they are quoting 65 to 70, ma'am, this year. We have a Rajasthan candidate coming, and for him they are quoting 70. No, it's a 3-year course, ma'am. The first year we get them to pass part 1 and part 2 ICO. And then the second year and the third year is completely taken up by Edinburgh University. And then they take care of clinical ophthalmology, basically. For 3 years. It has some nice installment also. Exam fee is different, but that's not that much. I think 30-40 days. The exam fees for the MS is no longer included in this, that everything is paid. But the exam fees for ICU, I think they have to pay. That I have to make sure. I think, yeah, you have to pay for ICU exams. And any extra exams you want to take MRCs or Part 2 class. Yeah. And also they are planning to send them to cataract fellowship also. To Erode. That will be part of, no, that will be extra. But it's part of the training. That is what we are planning. And also we are planning to send these footies to UK through DCI and dual sponsorship scheme and DI. Like if you have 3 to 4 years of training in ophthalmology, you can actually apply for a 2-year fellowship in UK, where you can get stipend of 3 to 5 lakhs. Okay. Great, no problem. Please, no problem. Okay, stop.
Okay, Kerala or
Most probably from Kerala. Tamanna madams. So related. Yes, girls. Where were we?
Culture and
So what can we remember one thing extra in program battle madness? That we need to have an anaerobic culture as well. Now Akhil will tell which is a good anaerobic culture.
summer hours, is it?
And summer it's for fungus.
Really,
Any search on Google. Good anaerobic culture or anaerobic culture example. Jinna is looking so sad in the camera that she's the only one who's standing. I'm feeling so bad. From now onwards, whoever is sitting will have to buy chocolate to return.
I asked music.
And he was something you have to sit after a while. Fatima is very smart, she always comes very fast. Let's extend her first and get the chair.
It's not particular medium they are not mentioning.
Okay, fine. Just will remember anaerobic culture, okay? Fine. Next, please.
Tire like
Thyroid,
yeah, I'm not sure. It's a reducing medium.
okay, then we'll
It's not,
mention thyroid, but we'll not consider this. Okay, so how do we treat, do you think?
So, sir, one more thing. You know, Robertson cooked meat broth
Yeah.
and also thiolaccolate
Yeah.
broth. Both are anaerobic.
Oh, great. That's why that thyroid is mentioned. He's saying thyroid since yesterday. Thyroid and a solid medium for anaerobic culture. P. Ekmas will be missed unless proper anaerobic culture is obtained. This is a very good MCQ part. They will try to trick us about this. Okay, girls, tell me treatment.
Initially treat as acute postoperative endophthalmitis as described previously, but do not start steroids.
Okay.
Second point, immediate pars plana vitrectomy is beneficial if visual acuity on presentation is light perception corpus up to 6 weeks after surgery.
How much is 6 weeks?
1.5 months.
1.5 months. So this delayed onset is talking about 1.5 months. If between 1.5 months, immediate vitrectomy is beneficial. No. 65 lakhs. If it is 65,000, then that's the best news. No, ma'am, you don't get it for surgery, first of all. It's at least 1.4 crores. Other places. Yeah, ma'am, it's very, very costly. And second thing is, yeah. And also, ma'am, in the other DO places, they don't train them for OCD, they don't train them for FFA, they don't train them with all these latest techniques, and they don't give them like 100 surgeries. We are giving trying to give them 100 standard surgeries. They don't even give 5 or 6. Yeah. Oh, she should ophthalmology here? With you? With you and Ahmed? Ah. Now she must rejoin. Okay. Ah. Yeah. Yeah. Okay, ma'am. Thank you. Wow. You're the so innocent. It's 61,000? No, 61 lakhs. 61,000, one phone. My phone is double that one.
Even government orders.
Yeah. Oh, everything is recording nicely. She can look at the video and Find out what I'm talking about. Yes, please.
Benefit beyond 6 weeks is
Ah,
not
So main thing is if it's like a 1.5 month post operating endophthalmitis, go for vitrectomy. If the visual acuity is below PL. So remember this: vitrectomy only if PL. Vitrectomy only if PL. Not all the things. It's not like one size fits all bumper offer. Everybody gets vitrectomy. Only vitrectomy is to be done in PL, and that too if it is within 1.5 months. If it is 6 months later, that is
invasive procedure.
it's a very invasive procedure. Like in certain conditions, then you don't know whether it will be good or not. Okay, there's no studies on that. Yes, girls. Good point.
If a fungal
If a fungal infection is suspected or vitreous smear is consistent with fungus, administer intravitreal amphotericin B 5 to 10 mg or intravitreal.
If fungal infection is suspected or vitreous smear has fungus, then give intravitreal amphotericin B and intravitreal or intravitreal voriconazole. How much?
5 to 10 mg.
No, it's not 10.
Mu.
It's micro.
Micro.
Micrograms. Or mu G or mu grams. Micrograms better. Now, how do you remember this? How much was acrobacin? Adina?
1 mg per 0.1
And what else?
so does it
2.25 mg per quantum. So how you remember this? Intravitreal amphotericin and voriconazole. You remember it like amphotericin B is very strong, so we only need 5 grams per. Why did you not mention the 5 grams per 0.1 ml? So 1 mg per 1 ml, 1 ml is everywhere, it's the same, yes? So it's 5 grams 0.1 ml. Then it is intravitreal cortisol is 50 grams 0.1 ml. If you remember this 5 and 50, it's easy to remember. If you put that 10 and 100 again, it's too confusing. 0.1, 1, 2.25, 0.1, 100. Rather, we'll say voriconazole is 50. Sorry, voriconazole is 50 mg, 50 micrograms per 0.1 ml, and amphotericin B is 5 grams per 0.1 ml. Yes, girls.
The time of vitrectomy.
And the time of it.
If fungus is identified on ground stain, Giemsa stain or calcofluor white, then consider topical antifungal. Example, netamycin 5% or voriconazole 1%.
So along with that, you also give natamycin 5% eye drops 1 hour. Like if you identify bacteria, you give oxyfloxacin 1 hour. Steroids 1 hour. You also give fungus is there, then actually natamycin 1 hour. Nothing to complicate here. Okay. Next.
And or systemic antifungal medication until specific organism is known.
Okay.
Consider consulting an infectious disease specialist for recommendation.
Yeah.
Antifungal therapy is modified in accordance with a therapeutic vitrectomy should be performed if it was not done with initial culture.
So till now we are doing diagnostic vitrectomy. Now it's doing therapeutic vitrectomy. Suddenly, like after giving the drugs, not initially. If it is PL, then it will do initially. Otherwise, you have to do Q1 hourly. Then you have to give natamycin. You have to give voriconazole. You have to give amphotericin 5. How much is amphotericin?
5
milligrams
micrograms
per
per
0.1 ml. And voriconazole
50 micrograms to 100 micrograms per 0.1 ml.
therapeutic vitrectomy should be performed if it is not in initial cultures. Okay, then please sit down.
Removal of the lens and capsular remnants may be required to diagnosis and treatment of
Removal of the lens.
Agnes, which may be sensitive to intravitreal penicillin,
Removal of the lens and capsular remnants may be required for diagnosis. And treatment of P. acnes, which may be sensitive to intravitreal penicillin. Cefoxitin.
So, when you're doing the vitrectomy, you're also supposed to remove the lens. It makes sense, right? Because it's post-operative endophthalmitis. No way on hell can you keep the same lens in there. When you do the vitrectomy, you have to take a whole goddamn thing out. No more capsule, no more lens. You should keep the patient FA kick.
That's it.
Yeah, so we does it, but it's better than becoming blind. Keep the patient FA kick, send him home, tata bye bye, then he come back 2 days later. Then you give him sulcus fixated IOL. Sulcus fixated IOL, which is not needing a capsule. And that capsule, if you count, the lens is required to culture it again. Then you try to find prokaryotic magnets. Then you try to find a bacteria. Then you do that culture on which cultures? Take the capsule and put them on which cultures? How many cultures? Huh? Tell me everything. First. Once first. Then.
Chocolate agar, nut agar, sabots.
Thigh-glycolate. Now we got something thigh-glycolate also. Good. It should be on the tip of your tongue, okay? If I call you into in the night, you should be able to take it like that. If you practice this enough, you guys will become very good. Okay? This is very, very rare. Nobody knows this cultures anyway.
So the
Thigh-glycolate.
is an arrow.
Now,
Next. So if you find bacteria in it, you should start with the penicillin or cefoxitin or clindamycin, vancomycin. If it is bacteria, start with vancomycin. If it is fungus, you start with natamycin or you can't do natamycin intermediate. Amphotericin or voriconazole. How much is amphotericin given?
5 to 10 microgram, 0.1.
And voriconazole?
50 to 100 microgram.
What's 100?
100.
50 micrograms per pound. If staph epidermidis is isolated, intraocular vancomycin alone may be sufficient. Obviously, follow-up dependent on the organism. In general, follow-up is described previously for acute postoperative endophthalmitis. Repeat CBC, serum electrolytes, and liver function tests 2 times per week during treatment for fungal edema. Why do we need liver function tests for this? Why do we need CBC, serum electrolytes? Hello? Yeah, hi, Dr. Yes. Right now we have a master's in ophthalmology course. 70 lakhs. 3 years. India. The exam will be conducted by the University of Edinburgh. In the first year, you will have an exam conducted by a UK authority called ICO. You have to clear the ICO part 1 and part 2. In the first years, and the second and third year, the clinical ophthalmology exam, the final exam will be conducted by University of Edinburgh. After that, your convocation and everything will be held over there. You have to go there and get the degree from them, and you have a master's that is recognized by the MCA or the NMC. Yes, they will do it. SEO is center. Islam is the center for SEO. So we have 100% passing rate for this. Not to worry. Yes. You have to pay installments. Yes. So I don't want to directly deal with finances regarding this. But I think it is something like 15 lakhs, then 20 lakhs, then 30 lakhs. Take care. Where are you from? Okay. So some better things about this is we also plan to give the students some surgical exposure as compared to other courses in Indian colleges which do not. We also plan to give some surgical exposure along with the OCT and FFA. Like you worked in Al Salama for 1 year, right? Yeah, so the OCT and FFA that we have in Al Salama is not part of any other normal government college. And we're also planning to try to send the students to UK through TIA route. Not everybody will be eligible, but if you are a good enough student through the 3 years with a good resume, then there's a high chance that you might get a 3 to 4 lakh rupees per month stipend in UK for 2 years fellowship. And after that, what you do with that is up to you. You can stay back in UK or come back to India or get a job over there. So that is also possible through our course. That is one of the big draws for this. So the surgical exposure, the exposure to the latest techniques. Because in UK, if you just go with MS in the most expensive 1.5 crore MS from a very good college, you have touched the Islam only 5 times, and they will essentially think like we are useless in India. But if you go through a premier high hospital with a private hospital training, with OCT, FFA background exposure, then they will really appreciate it a lot. That is their advantage. Otherwise, this Indian MS, they don't consider it that well as compared to this course, because this course has some sort of like a medical retina exposure, and these things are the advantage of this course. Okay, thank you. So follow-up will be dependent on the organism. In general, follow-up is as described previously for acute post-operative endophthalmitis. Repeat CBC serum electrolytes liver function test 2 times per week during treatment for fungal endophthalmitis. Yes, I know why he's doing that. Did you get it? He's saying repeat CBC, serum electrolytes means kidney, and liver function test means liver, 2 times per week when you're treating for fungal endophthalmitis. Because you're giving,
particularly
yes, because you're giving amphotericin B. Yeah, because you're giving amphotericin B and you're giving natamycin and you're giving, they're very nephrotoxic and toxic drugs. So during that time, you don't miss this point. When you're talking to the Viva guy, to tell them about that.
better if they mention here, right? Because then.
Yeah, this is it's very concise. It's like a senior telling you. It's not like a detailed lecture.
So if we tell like that, then we'll know that amphotericin has these effects.
So you have to tell this that if I start the patient on amphotericin B, if I suspect a fungal culture, if I suspect a fungal organism, then I would start the patient on natamycin and voriconazole and as a topical drop. I start the patient with intravital amphotericin. How much? 5 micrograms per ml. 50 micrograms per ml is voriconazole. I start the patient intravitally. Then I will start the patient on what is natamycin is drops. If it is fungal, if it is bacterial or propanibacterial macrocytes, I will start the patient on penicillin, clindamycin, vancomycin. The patient is having staphylococcus only vancomycin is enough. What else?
That also we can use in the next one.
You have to mention if I find that there is a fungal endophthalmitis going on in the guy, I will take care of the left ear and of the FT as well. Infrafunction test and along with CBC and cerebrometers. Okay, this is a good point. Today speaking, if you have clinical survey, you get his knowledge also. You'll be able to nicely compare these two things. Okay, Fatima,
So,
tell me from start to finish. Post-operative endophthalmitis. What are symptoms for post-operative?
sudden decreased vision, eye
Yes.
pain, eye pain after surgical procedures, then sinus,
I can see in the camera that you're reading out of the
Yes. sinus,
Don't read from the try to just
yeah,
Sinus.
sinus can be the beyond,
Twice, always correct.
yeah,
No, it's good.
fibrils,
Fibrin, anti-tumor reaction, vitritis.
then red reflex fluidity,
What else? What else?
cells,
Done. Next.
other organisms involved,
Okay.
most common is Staphylococcus,
Staphylococcus, Staphylococcus, Pseudomonas, and Propionibacterium. Propionibacterium is for
uh, delayed,
differential diagnosis and chronic post-operative uveitis. Workup.
complete operative examination,
Yeah. Slit lamp examination.
Yeah.
Examination.
then consider B-scan ultrasound,
If you cannot see the fundus.
fundus, cannot see
In
the
the slit
fundus.
lamp, you're supposed to see vitritis. You're supposed to see AC cells. You're supposed to see above. What else? Look for wound of blood. Look for blood. Exposed sutures, vitreous to wound blepharitis or other predisposing factors for endophthalmitis. Consider B-scan if you cannot see the thing. Then in the workup, you're supposed to send the thing for vitreous tap and aqueous tap.
Then that PL perception, and then steps.
A diagnostic vitrectomy is only done when you have PL minus.
PL
Okay, otherwise it's not done normally. On the other hand, you definitely do a 0.2 ml vitreous tap and a 0.2 ml aqueous chapel parasitasis. Then you culture them on where? Dina, where do you culture them? Fast.
Click on keywords from gram stain, blood agar, chocolate agar, sabons, thyroid bleach.
Treatment,
Prevention,
prevent it. Better to prevent it. Take care of your nurses, take care of your logistics and everything. Find out what is happening wrong. Okay? Give pivot and iodine perioperatively. It's a better word. Then, what else? Without looking at that answer.
atrophy,
Anil, do you want to answer this?
Observation in hospital. Steroids.
if it is a post-cataract endophthalmitis, we have to go for an immediate vitrectomy.
Design the elements. What else? In topical antibiotics we can give. You can also give intravitreal vancomycin.
Vancomycin and ceftazine.
Without dosages, you tell you have to buy me one chocolate. Ceftazidime.
2.25
Okay. This is not nice. This treatment is not nice. I need to find a better treatment. How many days? What are we doing? How much?
find a better answer sometime. Okay. Atrophy, okay, understand. Post-cataract, okay, understand. Systemic antibiotics also very bad point. Monitor
So antibiotic regimen entire
seems very, very bad. So what if it happens to so many years, so many months? Again, the symptom will be same, but it will be more incident this time. The signs will be symptom will be the same, but it will be more advanced. Like vitreous will have abscess. Anti-German hyperconjunctivitis will be granular exudates in the anterior. They will be what else? Okay, organisms involved will be proper and plus an epidemitis as well. How do we get to know that? Fungi can also be the cause. Different diagnosis are going to be post-operative. Chronic post-operative awareness. Workup again will be ask history, then do the examinations, then do the vitreous tab, do the aqueous tab, send for saborants, hybrid, and you can even miss if it's delayed onset. You have to give it an anaerobic culture, otherwise you will miss the diagnosis.
Complete CBC.
Then do the CBC, just like that, because treatment is about to be toxic for them. The treat it like it's acute post-operative anyway. Second thing is, if it is light perception suddenly and it is 1.5 months later, then you can still try for vitrectomy, but it's more than 6 months, then don't bother because you don't know what's going to happen. First try this thing. In the culture, when the culture reports are back, if you have bacteria, start with vancomycin. If you have epidermitis, start with vancomycin. If you have bacteria, start with penicillin, moxifloxacin, all those things. If you have, you can also give intravitreal vancomycin and ceftazidime, like how we treat it. If you have fungus, then you can give intravitreal amphotericin 5 micrograms 0.1 ml, voriconazole intravitreal 50 micrograms per 0.1 ml, and you can also give natamycin 5%, 5%. Yeah, natamycin 5% 1 hourly, and you can also give voriconazole 1 hourly for 2 days, something like that. After that, you can give a therapeutic vitrectomy. After this is done, then when they remove the lens and capture the fragments, culture them as well. That is particularly, this is very important. Here, P. acnes is again not even coming delayed onset of Endophthalmitis. And P. acnes, you have to do aerobic culture, one special thing. So the second thing is P. acnes, you have to take the capsule and the lens. That is where the P. acnes is sitting. If you don't see this point, then it will be very, very bad. Okay? So P. acnes is the one that is caused of delayed onset of Endophthalmitis. And if somebody is asking you about delayed onset of Endophthalmitis, definitely he will expect you to tell that the lens and the capsule should also be cultured. Otherwise, you will miss P. acnes. Because then what do? You follow dependent on the organism. In general, follow-up and describe. Follow-up it will be as post-operative, acute. And you repeat the CBC, serum electrolytes, and liver function tests, especially 2 times per week during or giving fungal endophthalmitis treatment. Okay. It was a very nice video.
You busy?
Class is good.
Class. Okay.
Please tell me.
Nothing. I just came. I was just getting bugged in my room, so just came down. No problem. Continue the class.
इसे पुट्ठी में डेट से बाहर क्या? What is this? Get it closer.
No.
Oh yeah, I was checking that. What happened? Want to see your face? Yesterday I found a great video on cornea. Next time, Dana is getting very bored, so next time we'll do cornea. Interesting.
Yeah.
I love to listen to cornea retina, very, very interesting. Otherwise, I will just getting very angry. Very trauma, cheap antibiotics.
Endophthalmitis was such a
Yeah, very.
disgusting.
To submit
But it's a good thing we finished it. Because it's very important.
It actually happens when we keep this stuff. Like
Sorry? Yeah.
it happens. It's like
Same here, but that story.
actual theory part is
Sonic system.
Convent quarters.
That 48 laws of power that guys commented. This book is so dark, not for the faint-hearted.
Yeah, it's like
Lola began to lose her sense of
This book is so dark.
yeah, I told you, it's like so many negative things.
This book at the same time can give people the wrong perception of morality, but at another time can give people the knowledge to protect themselves from being manipulated. If you know how bad people behave, you will that much more likely to save yourself from bad behavior. Maybe you might not use it that way, but knowing and not using that power rather than not knowing is always worse.
He's telling him to kick the other people down. So
Huh?
they can kick the other people down.
Yeah, he is a little bit too extreme.
Like, some of our morality isn't agree.
Yeah, you can
Our
always speak it.
morality.
You can always speak it. We have Islam anyway.
Yeah, that's what I'm saying.
Girls, we'll discuss one case and then you can take off.
Medical College. She came into the RP Center for her MD and then the senior residency and a short stint back in her hometown before she came back to RP Center and joined there. And currently she is heading the corneal and ocular surface clinic and cataract and refractive surgery. She has more than 100 publications and she the
This introduction is just to give us depression.
Like, yeah, no, nothing. Like that.
She has more than 100 publications. I just catch my hand.
we have about 10 cases of that case by one of the postgraduates, followed by getting into a differential diagnosis mode, and then pointing towards a diagnosis, and then move into discussing the case. Probably 7 minutes per case can give us somewhere around 75 minutes for 10 cases. Now, without wasting any further time, let us start the case. Meera, can you start presenting? And also, can you?
Okay, sir.
We'll try to
So, this is the anterior segment picture of the right eye with diffuse conjunctival condition as well as circumciliary condition, and there is a irregular shape
Feathery shaped border, corneal ulcer,
center involving epithelial defect
epithelial defect, yes.
with maybe yellowish infiltrate, and the can you see my cursor?
Yes, we can see it, Meera.
Okay. So we can see an epithelial defect here of size about 5 to 4 mm, and there is scarring in the temporal region of the ulcer, and also a dirty black to greenish pigmentation in the center, and also there are multiple yellowish infiltrations or branching pattern like lesions in the nasal part. Also, there is a convex shaped hypopyon in that direction. So it is most it's suggestive of a fungal corneal ulcer, mostly dermatitious fungus.
She described well. She didn't.
Meera, you are a first year student?
No, ma'am.
Second year.
Yeah.
Okay, you're finishing your second year?
Yeah.
Okay, great. I think you did catch on most of the clinical points here, and So when you start describing an ulcer, describing a particular picture, then you would say this is a clinical photograph, a color clinical photograph of the. So we
Right.
cannot make out the right eye or the left eye here. So showing the cornea and the adjoining conjunctiva. As you rightly said, there seems to be diffuse conjunctival eruption all around here. So we're not really able to say that's diffuse, but definitely there is a circumciliary condition. And you have a lesion involving the central cornea, about the central 5 millimeters of the cornea. And this you can see is an inflamed eye here, an inflamed ocular surface you're saying. So it is an active lesion, so it is a keratitis which you are seeing. Again, you're not able to make out an ulcer because there is no fluorescein staining on this, and you do not have a slit which is put on here which should be able to delineate the epithelial ulceration. Though you could sort of vaguely make out, but you cannot really tell for sure. So what you're seeing is a stromal infiltrate which is involving the central cornea, and in the superior part, so in the part from about the 1 o'clock to the 5 o'clock position, there is a mild, sort of a satellite lesions over here, a very coarse dendritic kind of stromal infiltrates. They all need to be deep stromal and not involving just the epithelium. In this region, it is definitely stromal here, and probably there is an epithelial ulceration in this region, but we cannot really comment unless we've done a fluorescein staining or we have a slit to delineate. This seems to be a fixed hypopyon here. So it's a hypopyon corneal ulcer which you're seeing, and this central reason would.
Do you know there is a fixed hypopyon and there is a mobile hypopyon? What does it mean?
Fixed means it stays.
When we work at that,
You thought she was saying no.
Yeah.
no, like that's adding on.
Yeah. Mobile is? Why?
The non-mobile is like more sticky, like the condenses.
Why? Why is one more sticky and why is one more mobile?
Maybe it's more serous.
One
Pussy.
hypopyon is by Geo and one is by no. One is by the fungus and one is by the bacteria. So what? Why it is? Yeah. So if I say fungus, you're not going to say which is sticky with it. You have to think in this way. Fungus grows like this. Like a hyphae. Look at this. Branches. Hello? बोलिए last sentence.
Confusion. Staying because condensing.
क्या हो गया?
Because condensing.
ठीक है तो 10 मिनट बाद So the thing is, no, fungal hyphae are going like this. Look at these branches. Bacteria just grows like this, like circle. Fungal hyphae grow in branches, like 3 branches. Okay? The fungal hyphae, they grow in 3D. They are intertwined in everybody. Every fungal hyphae is attached to every fungal hyphae, attached to every fungal hyphae. So it's a very dense hyphae thing. So it's very stuck like that. Whereas bacterial hypopyon is just like a water, like easily moving.
Seeing over here, which you probably thought was a epithelial defect here or the ulcer. This is a pigmented fungus which is growing on the superficial cornea. Okay. So this is why you rightly did say it's a dermatitis fungi, but when you describe, it's all there in the description for you here. So when you find this faint grayish brownish growth on the superficial surface of the cornea, that is a definite clinching point to show that this is a mycotic ulcer. So let me just ask you, when you examine this patient, what features other than what you have described will be, really points to say that this is a fungal ulcer? When you give a slit lamp evaluation, what would be staring at you to say that this is a fungal ulcer?
The feathery borders.
Anything? Anybody can join in. Anybody can
Yes, ma'am.
can answer this. I think some of my PGs are there. Is a very common.
The feathery borders. The fact that the borders are not well demarcated. And the fact that there is a hypopoion, and the fact that there is what else can I say? Just these ones.
The question which I always ask them in the clinical rounds.
There is a feathery margins we can be seen, and also elevated edges can be seen, and texture.
Yes, a dry looking ulcer with the feathery margins, right? Then
the dirty white or grayish appearance, and also sometimes there's colon button configuration, and also a fixed hypopoion.
Okay, so you have a fixed hypopoion. Something which will be staring at you is you find a significantly large ulcer which is sitting there. But when you examine a mycotic ulcer, the patient would be largely comfortable. So that would be one of the very important clinical signs which tells you that this is a fungal ulcer which you are examining. So usually you would have the signs more than the symptoms, which would be really, you'll really be able to.
He went to a wedding, started dancing. Something went inside, kept dancing. 1 day, 2 days, kept dancing. 3 days later, I was completely engulfed in fungus. Then he came. Bacterial ulcer, if it happens within 1 hour, the guy starts running and coming. So save me. Fungal ulcer is that advanced. Which is more dangerous, fungal ulcer or bacterial ulcer? Fungal ulcer. 3 days of dancing, he got blind forever. He had to go PKP, they got this cornering, forever is cornering. The bacterial ulcer, it pains so much, he kept running actually much more safer. Weirdly. Yeah.
Pick this up here. Of course, here you have a fungal ulcer staring at you. You have dementitious fungi which is growing on the surface of the cornea. So that's telling you that this is a fungal corneal ulcer which you're seeing. But your signs will overdo your symptoms. You will find a large ulcer and you put the patient on the slit lamp. He would be comfortable and would be looking at you without much photophobia or without much discomfort. Vis-a-vis, if this was a bacterial ulcer, you would find a significant amount of lid edema, significant amount of blepharospasm. The patient will have a lot of symptoms even for a smaller ulcer. So that would be a differentiation in an active ulceration caused by a bacteria and caused by a fungus here. So I think the rest of the clinical features we have largely described. So for you as postgraduates, you would probably want to look at, because we just have about 7 minutes for each, I think I'll just sort of trigger points which you have to go back and read is the various mycotic organisms which are cornea pathogenic. So it's all what you studied in your microbiology. So look at the classification of the fungi which can affect the cornea. So look at what are the common names here and what are the common ones which affect the cornea in terms of the geographical variation. So that's something which you will have to know. There is a definite geographical variation among mycotic keratitis in North India versus South India. I can see Dr. Anil here. Hi, Dr. Anil. Nice to see you.
Yeah, sorry that I got a bit stuck.
Welcome you to cut in my monologue and do carry on from here. Yeah. Yes.
No, I just wanted to ask Vanity, like when you said that there will be this fixed hypopion seeing this, it's because it's a convex upwards? Was it because of that? Because how could you say it's fixed hypopion?
Yeah. Would anybody like to answer Dr. Gopal's question?
Because it's a fungal ulcer.
Any of the PGs?
No, like how do we know it's a hypopion?
No, it's a fungal ulcer. It has to be a fixed hypopion.
Looking like a cheesy thick.
This usually
Only while we are shifting the patient, then only we can find out whether it is a shifting.
So
Moving.
here it's quite a thick coagulated hypopyon appearance which you are having here, and head tilt will help you to show that this is having a shifting position here out here. So you would be able to see whether it's shifting or not here, and then when it becomes thick and coagulated, it starts becoming a more of a fixed hypopyon, and you would not be having a fixating position here. Yes, Anil, you would like to take it on over the geographical variations?
Yeah, I think we have, like we have mentioned multiple times in the.
How do you know which is North India Fusarium, South India Aspergillus? Let's see.
For classrooms that there is definitely a variation between the North Indian. I think even last week we had a discussion regarding that. The Aspergillus is obviously much more common, and that's why the studies show that the voriconazole has got a much better effect in the studies from North India, especially RP Center. But the same story is not exactly repeated in Aravind Madurai or in Abid Hyderabad, because most likely because of the geographical variation. Fusarium is the dominant species in Aravind eye care system, and that too Solani, which is not really sensitive to voriconazole. So, if you have Aspergillus, it's probably slightly more advantageous in that we have two drugs and one voriconazole which has got a better penetration into the cornea and into the anterior chamber. But with natamycin, as you know, the penetration is very less, and so we are limited in our armamentarium regarding the treatment.
So if you have hypopyon, you cannot give natamycin. Natamycin is useless. But for fungal, you can start with natamycin. But when it comes to hypopyon fungal ulcer, it's better to start with the amphotericin, you put amphotericin. So you always remember whenever Shaji sir has the initial patient, you always start with natamycin. Doesn't waste any time. But then, as the time progresses, as the patient not that well responding to natamycin, he starts amphotericin 3.5%.
As Anil rightly pointed out here, that what you would like to do beyond this, yes, Meera, would you like to see once this is there in your OPD, how would you like to proceed and what investigations or management would you like to take this on?
Any of my PTs would like to answer?
How to manage it?
First of all, like Fatima always likes her favorite line, I would like to take a thorough history. Yes? When did it start? How did it start? How did it? Was it a vegetative matter involved? Was it a trauma? Was it some sort of penetrating foreign body? Anything. Yeah. Once I have confirmed that history, it just adds more to my confidence that yes, it is a native fungal ulcer. Secondly, I would like to do a colon scraping and do a culture on the cable spot, on a gram stain, on a sour or some blood, on a chocolate, on a thyroid. I would also like to do an anterior chamber paracentesis or an anti-chamber wash for the same thing, the same purpose. What else? I would like to do staining, find out the extent of the fungal ulcer, find out the depth of the fungal ulcer. I would also like to do slit lamp examination and put the corneal wedge and find out how deep the ulcer is.
First we'll do a corneal scraping, and then we'll send the samples for gram staining, KOH smear, and also we have to send for cultures also. Culture in the blood agar.
So when you say cultures, I made a mistake for the last 3 days by getting into 5 cultures in one. Run the smears on it, 3 cultures. KOH mount, gram stain or smears. I'm sorry, I misled you guys. 3 are cultures. Glycolate, sour blood, chocolate. 4 are cultures. Okay? Don't make sense. I know this because I know, so maybe you also know what I should have mentioned this one clearly. 2 smears and 3 and 4 cultures, like he said.
Subrox dextrose agar, then chocolate agar.
See how nicely I taught you guys.
That
you are able to deal on the level of this PG.
these are the only colors we need, right?
Yeah, that's it.
Back then we just so much.
You need one more for a cancer liver, but that comes when a cancer liver comes in your life. If you know this, you're this PG level, really, you're very happy. Tell your husband that I got a very good doctor today and he's very qualified. You should give me some sweets.
So yes, you would do a corneal scraping for this patient here, and you would send One is for doing, you would send your corneal scraping specimen, one for a smear, so you will make your slides. Whenever you say answer in your exams, your slides are for gram staining, which will help you to look at the cellular pattern of inflammation and particular organisms which you are looking for. And two, you would make a KOH stain, a potassium hydroxide wet mount stain to look for fungal hyphae. So these will be on your corneal smear examination.
Anything different?
No, same. Okay, same.
And you would send your scraping material to for cultures as well.
Ma'am, why didn't you comment on the fact that she didn't say to take history properly?
Maybe.
No, maybe.
No, like.
Doesn't it behoove them to take a history properly? Should they not at least mention that I would like to take a thorough history at this point? Having mentioned that the history was not going to take it. Second thing is, she jumped directly to culture. I would not have jumped. I would have jumped to staining. Staining seems more non-invasive. Less of a grade. And also, staining is supposed to be done before scraping because otherwise you're manipulating the ulcer.
So a direct plating is what is desirable if that is available.
It's a difference between FRCS Glasgow and
a center here. So direct plating will be on your blood agar plates to detect your bacterial growth, and if you're suspecting other fastidial organisms or non-aerobic organisms, you would choose your plates of agar accordingly here.
Anaerobic organisms. She also mentioned this. Because we're reading some detail. How many topics we have finished? 3 topics. And you're already 4. 3. And you're already thinking on level of expert PhD. Subject is part of it. Imagine if we had completed 50 topics, where your level will be at the time this year ends.
And then the next plate, as you rightly said, is for fungal usually.
Select your remaining days from 9 to 11 and from 1 to 5 before anything. I don't care where you guys are. Sleep in contact lens, wake up and 5 hours. 11 to 1 you have to give.
DA plate, which you
let everybody know this beforehand, okay? Even if they put in some classes, so we already have classes that have been planned by a very dedicated guy who always takes classes very regularly for us. You come once in a month to somebody take classes, anybody, Abhilash, anybody who just
to plate on. And in centers where you do not have a direct plating facility, you have what is known as a transport medium, which is available as a glucose broth. So
we have this transport medium because we don't have a direct plating method here. So we have a direct plating method here. We call them and they get the direct plates here. It takes about a few hours for them to get here. Okay? By the time they get here, it takes some time. Sometimes what we do is, had this facility not been there, like in Africa, in Nigeria, what they do is they put up the transport medium, they transfer it to the facility, and then from there they inoculate it in all the different mediums. They themselves inoculate
onto a glucose broth, and it's taken onto a laboratory where the plating is done, though this is not a desirable, but in several centers where which lack the facility of direct plating, then this is something which can be done. So this is how we would proceed in your investigation of this particular ulcer, and you know it is a fungal ulcer here, and several times your wet KOH mount will be able to pick out your septate or aseptate hyphae depending upon the type of organism that you're seeing. So do go back and look at your slides. So given the lack of time, we are not going to do that. So go back and look at your microbiology slides to look at the various appearances of how aspergillus is going to look at. Most of the time, fusarium, everything what you would find is a hyphae on slides, and the density would depend upon the amount you are able to harvest and put onto your slides here. And that would be a clinching diagnosis and helps you to start an empirical or help you to start a definitive antifungal therapy here. And when you're giving antifungals, you probably would not want to give a
what is she about to say? When you're giving antifungals, you'll probably not want to give why?
Maybe like something which is contradictory to the patient. Like if he is having any kidney problems.
I would give amphotericin in this case Should I not give natamycin? Is that what she's saying?
Antibacterial or a very low dose antibacterial if you're very sure it does not have a bacterial secondary infection, or if you want to give a broad covered bacterial, then you could probably add on a QID or a 4-hourly drops. Again, most of your antifungal agents, as Anil rightly pointed out, are poor penetration. So what you have is a diagnostic scraping. So when you scrape, you're creating an epithelial defect, and when you have an epithelial defect, the penetration and the bioavailability of the antifungal to the deeper tissues is better, and your healing rates will be much better. So that's one particular thing. And what we have is natamycin. We have amphotericin B, which has to be formulated. We have voriconazole. Itraconazole is an additive. We usually do not use it separately here because our other azoles are acting better here. But something which is new and coming into the anvil is the role of antifungal sensitivity testing here. And now we do find a lot of resistance to both natamycin, amphotericin, and voriconazole. And this probably is also a particular reason why some of our fungal organisms do not respond well. And also newer emerging organisms. So something in your exams you might be asked is what are the newer organisms? So do read about your characteristics here. Anil, would you like to chip in on that?
Not really, ma'am. We don't see much of Pythium keratitis here.
Yeah. So I also do agree. I guess either we are missing it because it's not as easy to have a microbiological slide to look at it and put it on as Pythium. So I also agree with you that probably I have not seen as many Pythium as which is being discussed on other platforms out here. Yeah. So your antifungal therapy, and you would look at on follow-up, you look at the resolution of the epithelial ulceration, the stromal keratitis, the resolution of the hypopyon, and if on medical management your healing pattern is not satisfactory, and if you have a chronic ulcer, meaning an ulcer being present on the ocular surface for over 3 to 4 weeks, then you have with the associated corneal thinning, you would consider a surgical intervention of a therapeutic keratoplasty. Anterior segment OCT imaging is another newer modality which now has a role to play in the management of fungal corneal ulcers here, that helps you to monitor the corneal thinning, and when your thinning goes beyond 50% of the stromal thickness is when it's going to alert your treating physician for being ready for a therapeutic keratoplasty.
Today we'll discuss this class.
I think anything, Anil, you would like to add on before we wind up?
It's interesting.
I think that's fine, ma'am. We had a fair more than 10-minute
discussion. The aim of this is to trigger all of you to what you should be looking at and what you should be preparing to study here. So here we have looked at the signs, the symptoms, the clinical presentation features, clinical features, the different type of fungal organisms which can cause corneal ulcerations here. What is the difference in presentation between Fusarium, Aspergillus, the corneal scraping, the media which are involved, then the antifungal agents which are available, their classifications, and what are their mode of action here, the dosages of these. Newer antifungals is something where some of your examiners might ask you about, and newer emerging fungal which mimic, which are into the pain is Pythium infections. So I think this much would broadly cover. And most of them, they would not take you into therapeutic keratoplasty in your questioning. And I'm sure that Anil has already taught you that in detail as well. Can we move on to the next?
Yes.
Okay.
Fine.